All right. Good evening, everyone. My name is Liz Zimdars, and I'm the head of adult services here at the library. I want to thank you for joining us for our latest presentation in our Scholar for Life series in partnership with Badger Talks. This series began in 2016 with great professors and researchers sharing a lecture on their area of expertise and representing a wide variety of academic disciplines. It takes the Wisconsin idea at its starting point and aims to promote lifelong learning, intellectual curiosity, and engagement between academics and the community as a whole. This evening, I'm so pleased to introduce Cody Wenthur, Assistant Professor of Pharmacy Practice and Translational Research at UW-Madison and founding director of the Psychedelic Pharmaceutical Investigation Master's Program. Say that 3 times fast. Dr. Wenthur's work is focused on improving our understanding of the beneficial and detrimental effects of psychedelics, opioids, cannabinoids, and other neuroplasticity-inducing drugs. These efforts are directed toward developing novel therapeutic approaches for promoting and maintaining mental health. And this is actually all part of our mental health awareness and healthy minds theme that we're doing this month. So please join me in welcoming Dr. Wenthur. Welcome.
Thanks so much, Liz, and thanks to the Middleton Public Library for the invite. Thanks to Badger Talks for helping set it up, and most of all, thank you all for being here tonight. I was just saying it was such a lovely evening. I was worried no one would feel compelled to show up because, we've had a little bit of a gloomy spring, but it's sprung now. So thanks again for joining me tonight. I'm a native Wisconsinite myself, so I grew up in Cedarburg. I'm here in Madison now, so I take the Wisconsin idea very seriously. Sometimes academics, throughout the course of your career, like any career, it might take you to other places around the country. But I very deliberately wanted to come back to the University of Wisconsin and give back to what I could to my home state. I think it's probably one of the best ideas in higher education is the idea that the university is part of the community, not apart from the community. And so thrilled to be here with you all today. So we're going to start with a little primer on psychedelics. We will talk about mental health as well. I will note that Liz isn't the only one who struggles with this program. We just call it PPI because it's too much to, it's just too much to say. But we'll end with a little discussion of kind of the more global landscape at UW and the way in which my research is plugging into the research of others, because there's actually a very vibrant and active community of students and researchers focused on this topic, including a relatively new center that we have that's supporting clinical trials in this work, as well as mechanistic studies and other scholarly activities around sort of cultural and legal and ethical considerations in this space. But we'll kick it off to start asking the question, what are psychedelics? This is the origin of the phrase. So Humphrey Osmond was a physician who worked in Canada back in the mid-20th century. And he was in communication with a well-known author, Aldous Huxley. Who here has checked out a book by Aldous Huxley from this library? Okay, maybe a third. He's got some good stuff. There's definitely a lot of good reading there. He wrote The Doors of Perception, which is a further literary reference to William Blake. And that was about mescaline and about its activity on modifying the actions of the mind. And he and Humphrey Osmond were in communication trying to come up with a name for this class of compounds that didn't seem to fit nicely into any of the buckets that were described by stimulants or opioids or dissociatives or other things. And Although Huxley was the author, he was stuck on phanerothym, which didn't catch on. But this little ditty was much more catchy. To fathom hell or soar angelic, just take a pinch of psychedelic. And so this neologism comes from psyche, the mind, and delos, to make manifest. So the idea is that these compounds reveal the inner contents of the mind. That's where the term came from. And the reason that they were given this name is that people have very altered perceptions of reality while under the influence of these compounds. And we'll talk about some details of that in a bit. So as a pharmacologist myself, I'm a pharmacist and a pharmacologist. We like to fractionate compounds into various different categories. And here, this is the drug wheel for psychoactive drugs. This is the space I find myself researching all the time. So we have things like stimulants, cannabinoids, opioids, depressants. And then these compounds, empathogens, psychedelics, and dissociatives, in the lay press, they tend to sort of get lumped together, and the lines can get a little bit blurry. Where I've put these lines in red is where you sort of see compounds in this wedge being described as psychedelics in the press, because, for example, MDMA, which is also known as ecstasy, it's methylene dioxymethamphetamine. It's an empathogen, but it's being used clinically or studied clinically in very similar ways that, for example, psilocybin and LSD are, which is as an adjunct to therapy, and we'll talk more about that. Similarly, ketamine is probably better called a dissociative, but it's here on this edge, and it's also being used in combination with therapy. And so if you look down this list, you'll maybe see some familiar players like LSD, which was famously discovered in the mid-20th century by Albert Hofmann and accidentally ingested, which led to a very famous bicycle ride and set off kind of a first wave of psychedelic research. Psilocybin is the active ingredient in so-called magic mushrooms. Mescaline is derived from psychoactive cacti and has been used by Mesoamericans for millennia. DMT is dimethyltryptamine, also a classical psychedelic. It can be found in grasses and isolated from other things. And then ketamine and MDMA, we already talked about being kind of on the edges of this and technically different classes. But psychedelics have a long, long history. I think in a lot of current discourse, right, dates around this time frame, right, between the 60s and 70s are kind of where people's mind goes to when we think about sort of the psychedelic era. But mescaline was actually isolated by Arthur Hefter at the turn of the 1900s. And actually, even that, right, that scientific study is missing 99% of our human experience with psychedelics. So there's essentially evidence of human use of psychedelics going back 6 millennia. So all of this sort of scientific perspective around what psychedelics are doing to the mind and how we can apply them is just a very, very thin layer on top of a deep, deep body of knowledge that has been stewarded and fostered by indigenous groups and actually form the basis for a lot of the protocols, for example, that are used in clinical trials, although the intent is extremely different. And so I think the most important thing that I want to say on that slide I already said, which is that this knowledge comes from indigenous practices. But the other thing that's important about this slide is that there was a fairly robust body of research and active engagement in the clinical space between the 1940s and the 1960s, which, while it didn't come to a complete end in 1970 when Richard Nixon signed the Controlled Substances Act into law, it significantly diminished the research on these compounds because they were scheduled as Schedule 1 compounds, which is the most restrictive class. It means that these compounds are considered to have potential for abuse and no legitimate medical use. And it wasn't really until kind of 2010 that we start to see large-scale studies coming back up in humans. And certainly now there's also other modern techniques being applied in preclinical models and cell models and things like that. Okay, so that's a little bit about what psychedelics are and their history. What have we gathered describing how psychedelics act on the brain? So these compounds are intrinsically fascinating to a lot of people because, as I said, they really change your perception of reality. You see things that aren't actually there. You can taste sounds. People often have a sense of a reality that's more real than their everyday waking consciousness, this sort of felt sense of there's an ultimate truth. And people sometimes report, it sort of all boils down to like everything is love. But no, not really, not like in the Hallmark card sense, but like really, really, like really, 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 like you don't. And so they fascinate people because there's this sense of like you can't actually capture what it is about them that's causing you to have A, this altered experience, and B, this altered sense of what constitutes reality overall. But now we can understand how they act on the brain, and we've got great tools to do so. So if we look at the cellular level, what psychedelics are doing is they're binding to receptors on the surface of a cell. So in your brain, right, these are neurons, and they're responsible for all the activity that's going on, helping us have our daily thoughts and actions and everything that we're planning to do. And these receptors don't really look like that, but this is a shape-filling model of a serotonin 2A receptor. And classical psychedelics are agonists of this receptor. That means they turn it on. So there's a bunch of different types of serotonin receptors in the brain. I think there's 14, if I'm remembering correctly. And classical psychedelics, where those lines are drawn is basically, do you bind to and turn on that 2A receptor? None of these compounds are exclusive to 2A agonists. They're actually pretty promiscuous drugs. They'll bind to things like dopamine receptors as well, histamine receptors, adrenergic receptors. But 2A is really the one that seems to be responsible for the perceptual altering effects. And if we look at the structures of compounds, I know that's everyone's favorite thing to do is look at chemical structures. Serotonin is a neurotransmitter in the brain. It's a common target of antidepressants like selective serotonin reuptake inhibitors. You may have heard of Zoloft, for example. Those compounds modify the actions of serotonin. They increase the amounts of it in the brain. And you can see that in red, I've highlighted the structure of serotonin hidden, right, embedded in these other compounds. So it's not extremely surprising that they bind in the same place, because if you have a lock and a key, and the keys have all these same features, you may open the same lock. So in addition to those molecular actions, there's really three major areas that people are working on right now to understand how psychedelics sort of catalyze long-term change in the realm of behavioral health. And one of those is the area of neuroplasticity. So there's an idea that dates back to William Hebb called Hebbian plasticity. So your brain, it learns, right? We learn every day. Hopefully you're learning right now. Maybe you're going to unlearn some things you thought you had learned. The way that our brain changes is through rewiring itself. And Hebbian plasticity basically says neurons that fire together wire together. So if two cells are in communication and they're speaking across a synapse, you can actually change the strength of that connection over time. And this is the idea of plasticity. And psychedelics can modify this plasticity. We also talked about how they can alter perceptual effects and cognitive alterations. And then they also can change the brain networks and the ways that they work together. And really, it's hypothesized that it's the confluence of these three things: the cognitive alterations, the neuroplasticity, and the disintegration and reintegration of standing networks that lead to long-term behavioral changes, things like diminished anxiety, reduced helplessness, lessened suicidality, decreased substance use, and suppressed chronic pain. So I'm not going to spend a huge amount of time on this slide. It gets a little wonky. If you guys are really deep into intracellular signaling, please ask me questions about it at the end, because I love it. But the point of this slide is if psychedelics are turning on the same receptor that serotonin is turning on, and serotonin is a neurotransmitter that's in all of our brains doing its thing right now, why aren't we having a psychedelic experience all the time? And the thought is that although those compounds look very similar, they're not identical, right? And you can actually get different pathways downstream of signaling, where you can have compounds that bias towards pathway A, for example, or pathway B. And here I'm showing you two more chemical structures, one of R-lyseride, one of LSD. You don't need to memorize them, but just looking at them, you can see they're very similar compounds. This one is non-psychedelic. This one is psychedelic. And if we look at the way in which these compounds change gene expression, you can see the non-psychedelic compounds cluster and the psychedelic compounds cluster separately, where there's specific markers, things like EGR2, again, don't memorize that, that differentiate between what a psychedelic has, what actions a psychedelic has downstream of the receptor and which ones don't. Another really interesting recent finding is that psychedelics actually promote the restructuring of neurons. So we talked about changes in synaptic strength, but the synapses also have to reach one another. So you have these dendrites on neurons that are reaching out. They have spines that are coming out and making those synapses. And if you incubate human neurons with increasing concentrations of compounds like DOI, DMT, and LSD, all of which are psychedelic, you can see the growth of these new neurites. You can also see the growth of spines. This is where those synapses would be generated. And then if we look at markers of things like VGLUT1, which is the vesicles that release those neurotransmitters, or PSD95, which is a marker of synapse generation, you can also see the generation of more synapses with these compounds. And has anyone read Michael Pollan's book, How to Change Your Mind? So there's one color figure in that book. I believe it's this one. He sprung, the publisher sprung to make the figure part of the book. So, it's important enough for him. I think it's important enough for us. There's also these systems level effects. So in your brain, there are certain regions that like to talk to one another more commonly than others, right? Your whole brain is not doing everything everywhere all at once. It's doing certain things at certain times, right, in a way that's helpful. And so there are several different ways you can categorize this by activity, but these are some fairly canonical networks. So for example, if you're processing visual information, you'll get activation of several related regions. If you're processing auditory information, you'll get different information. If you're processing visceral or sensory motor information, you'll get different ones. And then you also have networks like the default mode network, where everyone close your eyes. You just activated your default mode network by doing that. You're just doing nothing, you're just breathing, you're just being. That's your kind of idling network, right? Then there's the executive control network. If I asked you to do a math problem, for example, or something like that, that might get activated. And so normally, these networks are talking within one another. So regions of the brain back here are talking to regions up here when that network is engaged, but they're not talking to these other regions. And you can see underneath placebo conditions, these lines are connecting different regions of the brain. So each one of these circles is one of the regions of interest. The lines are connections between them, and you can see most of the connections are within a given network. Underneath psilocybin, you see a much more chaotic picture, actually. Sometimes this is called the anarchic brain, where you get connections between and within networks. So I told you you could hear a color, for example, on psychedelics. That may be because your visual and auditory networks are far more intermingled under this state than they are underneath everyday waking consciousness. Okay, and then the last thing is, what does the psychedelic experience look like? This is hard to quantify, right? I said people come back and they have this felt sense that they learned something important or they saw something important, but often it's extremely hard to articulate. And so how do we even study that as scientists, right? How can we reduce something to a reproducible phenomenon? So there are scales like the 5-dimensional altered states of consciousness questionnaire. There's also the MEQ, the CEQ, the EBI. There's a bunch of different flavors of these that basically take the experience and try and pull it apart into different pieces. So we talked about audio-visual synesthesia. That's that blending, right, of senses. We talked about the idea that you might see things. So this is elementary visual distortions are things like you'll see a gradient or a moire pattern. You might see vivid imagery. Some people, if you have a high enough dose, will report seeing, especially under DMT, entities, for example, and entire other realities. But then there's also, non-perceptual changes, things like, did you experience unity? Did you lose a sense of yourself and you actually were part of the greater environment? Was there bliss associated with it? Conversely, was there anxiety associated with it? Was it a very difficult, challenging experience? Were you having a hard time controlling your thoughts or having a normal cognitive process? Did you feel like you were out of your body? And you can see on this plot that as we go out, the further out we are from the center, the more that was reported in this study. And here we have a low, a medium, and a high dose of psilocybin, which again is that active compounded magic mushrooms. And you can see that it's very reproducible and dose scalable, which is useful if you want to understand the way in which we put together our everyday reality, to understand what happens when we take it apart, and to be able to do so reproducibly as a scientific tool. So one question you may be asking yourself, among others, is, are drugs alone really enough to produce real changes in mental health? And I would say the answer is no, but they are one way that we might leverage other tools that help us improve mental health. So this is one model for how psychedelics might do this. We're leaving winter behind, but I want you to imagine not so many weeks ago, a field that was just covered with freshly fallen snow, right? So if we get a foot of snow and someone's going to walk across it, they'll cut a path, right? The next person is going to go, well, I didn't wear my winter boots because it's April 30th and I wasn't expecting it to snow a foot. I'm going to go on the same path as you, right? The third person will go down that path. The fourth person will go down that path. Neurons that fire together wire together, right? So the same thing happens with your neurons, that paths you use form stronger and stronger connections. And folks who have disorders like anxiety or depression can get in this cognitive rut where you have very strong connections between elements in these networks that we just looked at. And the idea is that psychedelics can weaken those old connections like we just saw. They're kind of causing this chaos. It also enables new connections to form across. And then in theory, you can have cognitive escape from that rut. You've weakened the old connections, and you now have the opportunity to tell new stories about yourself in combination with what is, for most people, an extremely novel and different experience than what is going on. But just because it's different, right, doesn't mean it's better. There's lots of people who report very challenging, very negative experiences underneath psychedelics. And just having a more plastic brain, again, doesn't mean that it's better. It could be receiving inputs that are, again, more challenging or more problematic, especially if you're embedded in an environment that's contributing to negative mental health in the first place. And the idea is that activation of this 5-HT2A receptor, the serotonin receptor, puts you in this pivotal mental state where you can change where you are, but it isn't really a directional sense. And there's a really great narrative paper by Ari Brower, who's a postdoc here, as well as Robin Carhart-Harris, who's an active researcher in the field. It's a long paper, it's kind of a long read, but it's very interesting because it also talks about the intersection of stress and sort of religious ecstasy experience, religious ecstatic experiences, and things like going to a sweat lodge and those sorts of things that might also put you in pivotal mental states. So, because of that, when we're talking about psychedelic use for mental health, they're not being used alone. They're being embedded alongside psychotherapy. And what I'm showing you on this slide is the study diagram, basically, for a psychedelic-assisted therapy session. This actually, I believe, is from an MDMA-assisted therapy trial, where each of these orange blocks is a preparatory session where someone is meeting with a therapist to talk about what they're going to experience, to talk about what they're going to work on, to talk about what their symptoms are, triggers, things like that. The red blocks are where they're actually being given the drug. And then the green blocks are where you're coming back for therapy, not under the influence of the drug, but integrating that information, talking about what did you see, feel, hear, what did it bring up, how can we move past that, how can you think of strategies to improve, right? And so you can see this is a lot, right, of therapy. And so anytime you see an article, right, that says like psychedelics show efficacy for depression or something, remember that the drugs are being used as an adjunct or a helper to therapy. And so I think it's implausible that use of psychedelics outside the context of therapy is going to be intrinsically helpful for people who have active mental illnesses. Embedded within this, the therapists undergo a lot of training. As we pointed out, there's these prep sessions, these orientation sessions. There's a lot of work around developing a therapeutic alliance, developing trust, right, with that therapist, and then integration. And finally, there's this setting, and support, which is very different than a lot of compounds. And the idea is that we're not just putting you in a white clinical space, pumping you full of psilocybin and letting you go on the journey. There's two folks in the room who are there to help support you. They often say that they're kind of holding the space, they're making you feel comfortable, they're allowing you to focus inward. This is part of the preparation session, is telling you, what it is you're going to be working on, what you're going to be experiencing. You can see this person is wearing eye shades, they have headphones on, there's usually music playing, there's a weighted blanket, and then this room is much more like a living room setting than a clinical setting, right? And the idea is that psychedelics often act as kind of meaning magnifiers. So to go back to Aldous Huxley, we're going to do a little interactive piece again. Look down at the legs of the chair you're sitting on. Any profound realizations about the nature, the fundamental nature of the universe, or no? So in his book, he said the chair legs were Saint Michael and all the angels, right? These often extremely mundane things feel extraordinarily important under the influence of psychedelics. And he was thinking about, right, Blake, and he was thinking about these religious influences, and he was thinking about sort of the texture and nature of reality. So he also goes on and on about his pants, right? But he sort of had these primes in his mind that were being amplified, magnified by the psychedelic, right? It's mind manifesting. What were you already thinking about? Turn that up to 11, 12, right? And so having someone in a frame of mind where they're thinking about healing, thinking about support, thinking that they're safe, can actually be a really, really important element of modern safety protocols for these trials. Okay, so that's how we're doing it. What's the evidence that this actually could work to improve mental health? We'll start with ketamine. This is a pretty complex figure, but I'll try and walk you through it. So here we're looking at a meta-analysis. That means each of these blocks is a different study. And we're looking at evidence across a bunch of studies, right? So taking a lot of scientific literature, a lot of experiments, and putting them together to see, does something meaningful fall out? And here we're looking at treatment-resistant depression. So these are folks who've tried a lot of different things, usually at least 3 courses of different therapies to address their depression, none of which have been sufficient to alter the course of their disease. And we're looking at 3 time points, 24 hours later, 7 days later, and then overall. And on this line is the dividing line for saying placebo is better or ketamine is better at reducing the symptoms of the treatment-resistant depression. And you can see that at 24 hours and 1 week later, and overall, ketamine had a better effect. These data were actually used to support the approval of a drug called S-ketamine, which is one particular enantiomer of ketamine that's now FDA approved for treatment-resistant depression. It's an intranasal form. You can see S-ketamine here, intranasal with ketamine IV. And in this case, we're actually looking at suicidal ideation. Similarly, if these bars fall on this side of the line, placebo is better. Over here, ketamine is better. So for both IV ketamine and S-ketamine intranasal, they actually had a uniquely supportive effect for suicidal ideation. Both of these are pretty impressive because things like Zoloft, which we talked about, for those folks in which it does work, it still takes usually 6 to 8 weeks for the onset of that drug. So for something to work within the first 24 hours was very exciting. And actually, a lot of this ketamine literature was sort of what set off the excitement for kind of the second wave of psychedelic research. If we look at psychedelics for mood and depressive symptoms, so here we're looking at ayahuasca, which is a word I haven't mentioned yet. It is essentially a psychedelic potion that comes from the Amazonian basin. It's 2 plants that individuals there identified and use to induce a psychedelic experience. The active component of ayahuasca is considered to be DMT, which I did mention. It's a classical psychedelic. Interestingly, that second component of the plant contains an inhibitor of an enzyme that would otherwise break down DMT and make it so that it doesn't act when you take it orally. When you ask folks from the Amazonian basin, how did they know to do that? How did they find these 2 plants out of the tens of thousands of combinations? They said they watched the jaguars. The jaguars would eat this one plant, they would eat the other plant, and that the jaguar showed them how to do this. And I'm not doing the full narrative justice because it's not my tradition, but there's a fascinating and very impressive pharmacology story there. Psilocybin we talked about. So in this case, we're flipping the script, so psychedelics are better on the left than on the right. This is just a convention of how someone decided to show it. Again, looking at short-term, medium-term, and long-term effects, now up to 60 days. And you can see that across ayahuasca and psilocybin and all groups that we have superiority over placebo for these mood and depressive symptoms. This is one of the latest, biggest trials that we've got. So Compass Therapeutics is working on this. So in clinical studies, you go from phase 1, which is largely a safety study, to phase 2, proof of efficacy, to phase 3, which is a large full-scale clinical trial where you're trying to see, does this work across a bigger population? This is a phase 2 trial. There are approximately 200 individuals in this trial. To orient you to the graph, this is a MADRS score. It's a measure of depression symptoms. So if you have a change in this score, if it's going down, that means your depression symptoms are getting better. Here we're looking over time. So this is 2 days after dosing, 1 week, 3 weeks, 6, 9, and 12. And the 3 lines we're looking at are 1 milligram of psilocybin, 10 milligrams of psilocybin, 25 milligrams of psilocybin. And you can see that there's this rapid decrease at day 2 and symptomatic improvement that persists out through week 6 significantly with a 25 milligram dose. I will say that that's one phase 2 study. There are ongoing phase 2 studies from USONA, which is a spinoff of Promega down in Fitchburg. They're doing a phase 2 study for general major depressive disorder. We'll see what that data looks like, if they're good or if they're not as good. Sometimes things that look good early on don't look so good later. These are even smaller trials, but they've launched further studies. So alcohol and tobacco use. So this is measuring the percent of heavy drinking days over time. And you can see rapid decreases in heavy drinking days with psilocybin. Here we're looking at how many cigarettes people are smoking per day. This is at 10 weeks, 6 months, 12 months, and over the full duration of the study. And you can see massive decreases and persistence of reductions in cigarette smoking with the psychedelic-assisted therapy approach. This is all good, this is all exciting, but there's a huge amount of work that's going to each of these trials. There's a lot of focus on therapy. There's a lot of individual effort that's put into it that may not be able to be recapitulated. in a general sense. And in a lot of these trials, it's also basically white, well-educated urban folks. So generalizability is a real consideration for what we need to do. Cancer and end-of-life anxiety and depression is another area. I would say this trial probably launched the true beginning of the kind of the second wave of excitement about psychedelic-assisted therapy from Roland Griffiths and colleagues at Johns Hopkins. So here we're looking at a depression scale. Again, going down is better. This line is considered to be the level of remission of depression. So folks who got the high dose, we see an immediate reduction and persistence up through 6 months. The folks who got a lower dose, we saw some decline, right? So that's probably because we know therapy alone works, right? There's also placebo and expectation effects that are probably driving part of this. And then when they get the full dose, they also fall below this line. And their quality of life increases. So this trial was very exciting to people because we don't have diagnoses for existential distress, right? If you're diagnosed with cancer and someone tells you it's terminal, you have 6 to 9 months to live, that's a heavy load. And people aren't good at coming to terms with their mortality, or not everyone is, right? And it can cause very severe anxiety and depression in folks. And this appears to be one tool that we might be able to use. And there's a lot of interest in training palliative care physicians, chaplains, and other individuals, spiritual care leaders, to potentially use this as a toolbox to address, in their toolbox to address it, for those who are interested, of course. And the last one I'll show you is MDMA-assisted therapy for severe PTSD. So similar scale as before, but now we're using a CAPS-5 scale, which is a PTSD scale. Scores lower are better. If we give therapy alone, we can have people improve. If we add MDMA to that, people improve more. This is a Sheehan disability scale, so another measure. We see the same thing, right? That adding the drug onto the therapy is improving the outcome of the therapy. And if we look at the end of the study, here we can see that we can see responders, loss of diagnosis, and full remission. This is the therapy alone group. The higher you are, the more percent of participants experience that. On the right side, this is the MDMA group. You can see more individuals across the 3 sessions were responders, had loss of diagnosis and remission. So that was 2/3 no longer met the diagnostic criteria, as compared with basically 1/3 for therapy alone. And then 1 out of every 3 met the criteria for remission versus 1 out of every 20 for placebo. So these are aggregate data. It's good news. This was the first phase 3 trial. The second phase 3 trial results will probably be reported next month. If they look equivalently good, they're going to submit to the FDA at the end of this year for authorization to try and get approval basically in the first half of 2024. So MDMA-assisted therapy, again, if these results continue to look good, will likely be the first out the gate for approval. I think one thing to mention here that's really important is, again, they're aggregate results, right? So people hear this and they think everyone gets better, right? That's not the case. There are certainly some people who are getting better, but it's not a magic bullet. It's not a cure for everyone, for any of these conditions. But that's good data. That's exciting results. But I think often in the press we see, sort of psychedelic exceptionalism and exuberance about what they can do. But remember, there are people in this trial for whom this did not work. Okay, so that's the good stuff. Every drug has bad stuff, right? I'm a pharmacologist, I'm a pharmacist. The notion of the pharmacon is deeply embedded within me. So there's this very old idea that no drug in and of itself is good or bad. It's the dose only that makes a poison, right? And so to me, every compound comes with positives and negatives. These compounds do have negative sides. So things that we've seen in psychedelic trials, people will have elevated heart rate and blood pressure in the first 60 to 90 minutes. That does seem to resolve, but for people who may have underlying cardiac instability, that could be a reason to stay away from these drugs. Headache is very common. Almost everyone ends up with a headache in our trials. That occurs essentially sort of 8 to 16 hours later. If you give acetaminophen or Tylenol 325, it works pretty well. Nausea is present in some individuals. Vomiting is very common with ayahuasca. MDMA comes with a lot more risks, actually, than the clinical psychedelics. It has much more of a stimulant character. There's muscle tightness, decreased appetite, sweating, dizziness, chills. And in about less than 1% of individuals, they have reported potentially risky disorientation or delayed or lingering psychological symptoms. So it's not that many people, but those could be very significant and severe. These compounds certainly have potential for harm. If we compare them to drugs that we know and many people in Wisconsin love dearly, like alcohol, the risk of harm to others and harm to users is far lower for LSD or magic mushrooms as compared to alcohol. But the risks are still there. And again, there's this whole container, this whole therapeutic container that's being put around these compounds. So in non-clinical settings, bad trips are fairly common. This is a survey of 1,300 individuals talking about their worst bad trip. About more than 1 in 10, about 1 in 9 actually report putting themselves or others at risk of physical harm. 2.5% reported being physically aggressive or violent. 2.7% needed medical help. For those whose session occurred 1 year earlier, 7.5% reported seeking treatment for psychological symptoms. 3 cases had an onset of psychotic symptoms, and 3 cases were associated with attempted suicide, right? So these are much higher rates than I just showed you in clinical trials. So there are special risks to using this in sort of a naturalistic setting, and there are certainly very severe risks. One of the reasons that in clinical trials we exclude people who have a family history of psychosis is that there is this small but real risk of inducing a psychotic break in individuals. So just a little bit of harm reduction here. So the risk of harms for psychedelics, the risk factors for dangerous behavior is, again, someone who has a history of a psychiatric disorder, and particularly a psychotic disorder, someone who's inexperienced with the drug, has poor information about the drug, is combining it with other drugs or alcohol, and is using with an unknown or untrusted individual. All of these are things that amplify that risk of a bad trip and negative outcomes, and so should certainly be avoided. These are 2 groups that do peer support and real-time counseling for individuals who find themselves at a festival or something where they took too much, or they took something they didn't know about, or they took it with other drugs, and they need a little bit of real-time action on that front. Okay, what are we doing? One of the things that we're doing is looking at ketamine. So we're looking for combinations that are resulting in ketamine's antidepressant effects. Ketamine itself is metabolized into a whole bunch of different compounds. You can see them down here. And there are suggestions that some of these metabolites may be contributing to the antidepressant effects, but don't have the rewarding effects that ketamine has. So ketamine is a drug of abuse. People have overdosed on it, unlike other psychedelics. Remember, this is in the dissociative class. It's actually used as an anesthetic. If you were to go to the hospital and get a surgery, there's a good chance you may get ketamine. So if you take too much of it, you can go in a coma. If you take way too much of it, you can die. It also, like I said, has rewarding effects, and some people do abuse it, although certainly not to the numbers of things like heroin or cocaine. But the idea is, if we can find a compound within this metabolite group that has a different target and a different mechanism of action, but nevertheless has antidepressant effects, that could be a valuable way to reduce some of the harms while retaining some of the benefits. And we actually think that it's probably a combination of ketamine and this metabolite, 2R6R-HNK. And so what we do is we take compounds that look like ketamine or like that metabolite, conjugate them to a protein that will cause you to create an immune response, and you can generate antibodies actually against these molecules. Because the molecules need to get into your brain, if you have antibodies against them, we've essentially created a pharmacokinetic sponge in the periphery because there's a barrier between your blood and your brain that doesn't allow big things like proteins through, although it might allow small things like drugs through. And so we can use that to pull apart, right, this very complex mixture and say, you are not allowed to cross the blood-brain barrier. So then we can tease apart what it does in relationship to all these other compounds. And what we see is that if we remove the 2R, 6R, H, and K, we actually can lose some of the antidepressant effects of ketamine. And then the other thing that we're doing is this is a mouse brain. We can actually take these and optically clear them and then look at which neurons were activated underneath the drug conditions and assess, okay, if ketamine is on board, which neurons were activated? If hydroxynorketamine is on board, which neurons are activated? And if both are there, do we actually get synergistic activity? Do we get something new and different that doesn't occur with either independently? One of the other things we're doing at UW, and I'm a part of, is trying to assess whether the psychedelic experience has therapeutic causality. Like I said, people mention that they feel different, right? They tell a different story about themselves after taking psychedelics. But they're also doing all this interesting stuff at the level of neurons, right? That doesn't rely on you seeing your dead grandmother and her telling you it's okay, right, to hold trauma or to have problems, right? And so it's possible that you can remove all of the psychedelic piece and still get therapeutic outcomes, which would drastically actually simplify the way that you give these. But that's an empirical question. And I would say a lot of people who come out of these trials are not, they say, you're crazy, like that's not going to work. But it's really important, I think, that we ask the question because it has huge impacts on accessibility, risk, and our understanding of how they're working. So Chris Nicholas is actually the PI on this study. There's a whole other list of folks: Matt Banks, Randy Brown, John Dunn, Paul Hudson, Rick Leonards, Charles Razan, are working on this trial. Recap, where we're basically giving psilocybin plus midazolam, which is another agent that you might get. If any of you have gotten a colonoscopy, you're getting a similar dose of this. I hope you don't remember your colonoscopy. It allows you to be sort of awake and alert, but then forget the experience later. So what we're trying to do is capture that people had the experience, but then have them forget it and see, do they still get better over time? One of the other studies we're working on is understanding the role of stress, self-identity, and set and setting interactions in psychedelic-assisted psychotherapy. So here we have another view of that dosing room that I talked about. I've blurred the art because the intervention that we're working on is having people select their own art to match with their own self-identities and to see if that helps them, A, enroll and stay in the trial, and B, whether it helps measures of things like therapeutic alliance that we think are going to cause there to be better outcomes long-term. And so all of this, right, is trying to create this serene sense of preparedness. But it's actually possible that serenity is not essential or necessary. So at the beginning, remember I said to fathom hell, right, or soar angelic. So there's certainly people who are having extremely challenging, hard experiences. And if we look at things like the challenging experience questionnaire, if people have very difficult experiences but then come through them, they actually have similarly strong outcomes as those that had sort of a highly blissful experience. And stress is a really strong and important motivator for learning. If you're being chased by a saber-toothed tiger because you went near its cave, it's really helpful to learn, don't go near that cave again because you're going to get eaten by a saber-toothed tiger. And so we're really interested in this notion of stress as a contributor. It's been seen that with increasing doses of psilocybin, so this is very low, low, medium, and high, you get increases in things like cortisol, which is a stress-associated hormone. But you also get increases in things like anxiety, that anxious ego dissolution, and that ego dissolution is negatively, sorry, that anxiety is negatively correlated with positive outcomes. But we want to know, can we dissociate the cognitive anxiety, right, from the biochemical stress response. Maybe these are working in opposition. And what we see in some of our studies is that psilocybin induces this acute transient increase in the plasma corticosterone in mice. So we're measuring that over here. We get this bump with psilocybin that goes away quickly. Here we're looking at head twitches over time. This is probably something you've never heard of. Unsurprisingly, we can't probe the mind of a mouse. I don't know if it's having a psychedelic journey, but there is this measure where they actually do something like if you have a dog and it gets wet, it'll shake to get the water off of it. They exhibit a behavior very similar to this one under the influence of compounds that are psychedelic in people. So at the same time that we're seeing these head twitches go up, they're having this court response. And what's interesting is mice don't like to be in the center of a room, right? If there was a mouse in this room, it would be skittering along the wall. And so we can use this as a measure of behavioral anxiety in a mouse. So at the time when that court is spiking, the more psilocybin they get, the less time they're spending in the center, right? They're anxious during that period. But if we come back at the time when the drug has left the system, we actually see the exact opposite thing, right? That now they've been inoculated sort of against this stress, and they're spending more time in the center later. So this might be pointing to the fact that acute stress could be helpful for long-term resolution. If we look at feeding in mice, so similarly, if we put a piece of food in the center of a chamber, like a really sweetened pellet, something that they want, they're going to hesitate to go in the middle. But if we give psilocybin and we wait till the drug has left, they actually take less time to feed. You can think of this like, okay, let's say there was a $100 bill laying on the floor, right? That's something you want, but also there's a bunch of other people in this room looking at you thinking like, well, who's gonna go get the $100, right? So the shorter time it takes for the mice to engage in the action, similarly, that would be a measure of reduced anxiety, right? If you're less anxious, you go like, whatever, I can take $100, and you walk up. That's kind of the measure we're looking at here. And then the last thing is, it seems to be important that this resolves, right? That it just doesn't spike and stay up. Because if we have the mice have a lot of corticosterone in their water over a long period of time, we see the opposite effect. So here, again, without corticosterone, we see that psychedelics are causing them to spend more time in the center. This is now 7 days later, so it's a long-term effect like we saw in people. But in animals that have this long-term elevation of cort, we see the opposite effect. It actually is reducing their time in the center and increasing their anxiety. So the way we're interpreting this is that an acute increase in cort is helpful, right? If you're having a challenging experience, that's okay. But if it doesn't resolve, if you don't have that integration, if you don't have that therapeutic resolution, that could actually be causing long-term negative outcomes. Okay, I see that I'm already going over, so I'll bring this to a close fairly quickly. As I mentioned, ethnic and racial representation in psychedelic medicine studies is not very good in the USA. We've got about 40% people of color overall. In psychedelic trials, we've got about 11% people of color. And that's a trend that's persisting throughout the globe. So we're looking at the role of environment, self-identity, and success. And the idea here is that if that set and setting influence psychedelic efficacy, right? The mindset that you bring in and where you are, influence it, and that self-identity influences set and setting. That, for example, if I see a crucifix on the wall versus Star of David, depending on my religious identity, you're going to have a different connection, right, to those items, or a medicine wheel, for example. Then the logical output is that your self-identity influences the psychedelic treatment efficacy through this lens. And here we have that exact example, right? So the controlled and the uncontrolled elements of the setting can interact. We're doing our best to control the guides, the tasks that people are doing, the music and the art, but everyone is bringing their own relationship to these other things to the trial itself. And so it's difficult to control for them if you have a rigid environment. And the idea here is that the set and setting can act as a therapeutic filter, basically. So if you have an identity that's congruent with the set and setting, you can pass through and get the therapeutic effect. But if you don't, you're blocked from getting it. And if we're largely running trials in a certain type of people, and the outcome of our trials is that we want people to get better, we're probably evolving our trial setting to be better and better fit to the type of people who are showing up in the trials, which is good for them, but not good for anyone who doesn't have that same identity. And what we're doing is using art objects to try and develop a quantitative fit scale for set and setting. So in Wisconsin, we could have this picture of the cheese shop. In Maryland, at Johns Hopkins, they could have this picture of the crab picker, so that people could connect to those items and have a better outcome. And so here we have, basically what we're trying to do is gather granular data on that. So say, how much do you like this object? What's the overall impression? How much is it connected to your age, your gender, your race, your locality, and psychedelic themes? And the idea is that we want to control for the uncontrollable, right? So if the set and setting is fairly good fit versus fairly bad fit, we can then use this to create a fit normalized effect where we say, okay, this is what happened, this is their fit, and then if it had been a better fit, this person, we would have expected there to be a 2+ effect basically for everyone. And really what we want to do is validate the idea of permitting patient choice in the setting, that everyone can choose their own art and the other things that connect to them so that everyone has the best possible fit, so we can have the best possible outcomes to do this sort of a thing where everyone has, where we have a set and setting that's flexible to match who you are. And we've been doing this in collaboration with the Madison Psychedelic Society, the Milwaukee Psychedelic Society. We've now done the Psychedelic Society of Texas, so Dallas, San Antonio. We're working on Baltimore, San Francisco. And what you can see is if we split participants into those who have a non-Hispanic white identity or any other identity, that there's no difference in how connected they think the room is to the locality or to sort of traditions around psilocybin. But those with a racial identity other than non-Hispanic white say that the room doesn't feel as connected to their racial ID, which is what we would expect if we've been sort of unknowingly moving the room more and more to fit the types of participants who are already enrolling in these trials. And so I think we can do a lot better job on that. Last note, this transdisciplinary center is our new center. Here is the website. It's going to update soon. There's members from across campus. We think it's extremely important that we're not just studying the biomedicine side of things, but also culture and history and ethnographic and anthropological portions of this work. I'm also the founding director of this program, so we have a master's program that's focused on CNS drug development, and particularly things like psychedelics and cannabinoids, understanding how we can incorporate these tricky molecules into safe and effective therapeutic models, and whether that's even possible. And then there's also a capstone certificate as well. So overall, we didn't go through this in detail, but it's certainly true that hundreds of thousands of Americans from all walks of life are dying every year from mental health associated issues. We have almost 100,000 people die from opioid overdose alone every year in this country. Right now, psychedelic-assisted therapy has positive clinical data for treating mental illnesses in the studies that lots of people have completed, but those studies are small, and that may not be true once we gather larger sources of data. Psychedelics have been demonstrated to have very low rates of addiction and overdose. They're sort of intrinsically pretty safe. The notion of someone overdosing on LSD or psilocybin is essentially a misnomer. They're quite safe physiologically. Certainly, there are massive psychological risks. Someone can put themselves at great harm and could die if they made an uninformed or negative choice on psychedelics, but it's not going to, for example, cause your heart to stop. And all medicines have risks, especially when they're used without knowledge. What we're working to do is understand how those psychedelic compounds work at a molecular level, how they interact with other non-drug elements of the therapy to try and optimize their effectiveness and improve treatment access. I think, to me, we can't leave options on the table when we're talking about so many overdose deaths, deaths of despair, people suffering with long-term PTSD that have basically no treatment options. I don't know if this is going to work, but I think it doesn't make sense for us to not try, given the positive data that's emerging thus far. And I think the other thing I want to say is, the last time I gave this talk, the hype train was sort of speeding up. I think there was a lot of negative stigma around psychedelics, period, that people didn't want to hear about this at all. They were thinking, this is a terrible idea in every way. Psychedelics kill people, and sort of trying to do anti-education on that front. But if you look in the press, there's tons of super positive, super over-exuberant news about psychedelics. So that's the other thing I want to leave you with, right, is these compounds aren't demonic, nor are they, angelic. They aren't perfect, but they're a potential tool, and we're excited to look at them and understand the ways in which we might be able to harness their positive effects and mitigate their negative ones. Lots of people to thank. Again, thank you all for listening, and happy to take questions. Yes?
What was the longest case you faced of your patient? Someone who took psychedelic, and how long you observed them?
Yeah, good question. So the longest data that we've got from a clinical trial setting comes out of the Johns Hopkins Cancer and End-of-Life Anxiety study. So again, many of those patients had terminal diagnoses, so not all of them are with us. But for those that are, the longest period of follow-back is now 4.5 years. And the rate of reductions in anxiety is I think it's 85% at the 4.5-year follow-up.
But for non-cancer-related depressions, how long is it?
Yeah, so the longest period of follow-up that exists in that population is 12 months. The persistence rate for that is not nearly so good. So we looked at the COMPASS data, right? And you saw that little asterisk which says this is the significant effect was gone after 6 weeks. So the notion, I think at one point there was a notion it's kind of a one and done, right? And I think that was because there's these unique features around kind of end-of-life anxiety and existential distress. For recurring, remission and depression, I don't think those same features are at play. And so there's a lot of people where the effect has gone after 6 to 9 weeks. And so if you need to give this therapy component over and over again, that causes really serious challenges for implementation. Perhaps insurmountable ones. Yeah?
What are sort of some ethical dilemmas that come along with doing human sort of experimentation, and how do you sort of screen people for these studies?
Yeah, so I should say that I'm not the one doing the screening, so I need to shout out Chris Nicholas and Randy Brown as like two major drivers, frankly, of the human subjects work. I'm doing a lot more of preclinical stuff. But the screening parameters, again, are looking for past history of psychosis, looking for really unstable housing situations, looking for folks who may have cardiovascular instability. We actually only enroll folks who live within like 90 minutes of Madison because they have to stay overnight. And I would say those are sort of the major ones. The ethical things that come up is around the question of informed consent. There are a lot of people who've tried a lot of different things. And so similarly to oncology trials, right, where people might feel like this is my only option left, it's a trial, right? We don't know if this is going to work for you or not. And so making sure that people really understand, right, that this isn't some magic bullet that you're going to get and get better is actually, I think, a really important ethical consideration for this population. Yeah.
Has there been much work or research around regular microdosing, like psilocybin or LSD?
So there is some. I would say it is not of the highest quality. It's a hard thing to study, but the studies that have come out that are of the best quality seem to indicate it works for people who are looking to be more creative or feel better, with the caveat that you have to believe it's going to work. It actually doesn't seem to differentiate from placebo, but placebo is a hell of a drug. And so if you have high expectation around it, it seems to work for people, but there doesn't seem to be a big pharmacological signal. So I'm pretty dubious, honestly, of claims that microdosing is super effective from a pharmacologic standpoint. And the other thing I should say about microdosing is we didn't talk about 2B, which is expressed on valvular leaflets in your heart. And if you activate that too much, you can get thickening of those leaflets. This is why fen-phen, the drug, was removed from the market. Unclear whether microdosing of psychedelics would cause the same thing, but a potential risk for people who are taking these over and over and over again, which is something we haven't really seen in the past. Yeah?
I guess a couple things. So you mentioned, I thought at the end there, maybe concerns about people dying because of, I've just never heard of anyone like dying from an LSD overdose.
No, that's what I'm saying.
Oh, okay.
If you've heard those concerns, like in the wild, right? This is a very common misperception that psychedelics are actively addictive. So so MDMA and ketamine we talked about are not classical psychedelics. There are instances of people becoming addicted to those. In the clinical trial setting, there's no follow-up, or there's no evidence from follow-up of people diverting or misusing MDMA. For the classical psychedelics, there's basically no evidence that it's possible to overdose from these compounds. But you could put yourself in a situation where you have access to something dangerous, right, like a car, and you get in it and you drive and you're not in a state to drive, right? So that's what I was saying, is it's not that they're without risks, but they don't cause direct overdose. Yeah.
So my actual question was, I noticed on one of the last slides you had like the UW departments, like I think sleep was in there.
Yeah.
So are you so I heard like anxiety and depression and PTSD. I mean, there's other mental health things. So eating disorders, people that have sleep disorders. Are those what's the word? I was looking for a word. Are those kind of open for testing, if you will, or those things that you're going after, or starting with the obvious ones, right?
Yeah.
Like depression?
Yeah, so not me personally, but the scientific community, if you can think of a mental disorder, there's probably someone going off to look at it for psychedelics. So a resource that you may or may not be aware of is clinicaltrials.gov. If you go there, you can look at all the clinical trials that are out there. If you type in psilocybin or LSD or DMT, I think there's something like 300 psilocybin trials registered recently, and you'll see things like OCD, you'll see things like eating disorders, you'll see things like Alzheimer's disease, and so, yeah. Do I think positive data is going to shake out for all of these? No, I think that's unreasonable to expect. But if you can think of it right now, someone's probably going after it because there's so much excitement from these positive data under these particular conditions. Yeah, back to you.
Another question. What are your thoughts on the possibility of patients who develop drug dependency? Because people can smell the cola, feel the air. They may just feel like they want to focus on the
Yeah.
again, and then they will go on the corner and will look for the drug.
Yeah, it's a great question. So we saw the data with alcohol and with nicotine. So actually here at UW, we're studying psychedelics to see if they are effective in reduction in opioid use disorder and reduction in methamphetamine use disorder. Your question is different. What happens if someone develops a dependency? And I would say I think this is sort of a persisting myth that psychedelics are addictive in that way. They are absolutely abused.
Not because they're addictive like in chemical compounds, but people have experience.
Yes.
They may go for this experience again.
Absolutely. I think that's totally accurate. They are abused and abusable compounds. And my thoughts on that are, if people are exhibiting symptoms of substance misuse, right, or abuse, then it is unethical, right, to continue treatment with that compound, because by definition, right, those diagnostic criteria say that it's hurting your quality of life, right, and your ability to be a productive member of society. And so I think your concern is a totally legitimate one, that there is possibility of abuse and misuse, and we need to watch out for it. I would say that the thing that is inaccurate and has been portrayed inaccurately is that they're chemically addictive compounds.
I was just wondering if you could talk a little bit more about the setting. You talked a little bit about artwork. I saw an earlier slide, somebody had a blindfold on. I'm just curious kind of what are the typical features. I know it sounds like you're still studying how things work, but I'm just curious.
Yeah, so the typical features of the clinical trial setting are that it's in an enclosed room. There usually are no windows or other things to look out of. There are generally, actually exclusively right now, there are two individuals in the room, one of the same sex as the participant, one of the opposite sex. Both of them are trained either therapists or psychiatrists or psychologists. Usually there is a playlist that's being played on wireless headphones. Generally there is an eye shade and a blanket because some people do get cold, for example. And they're usually in that room. It depends on the drug because they all have different lengths of action, but for psilocybin, we're usually doing a 25 milligram dose. That's about 6 to 8 hours. So then there's also a couch for people to lay on. There's a bathroom right there on site. There's snacks, refrigerator, etc. And then decorations, right? And that's the part where it's like, I think we think it's important, but we don't really have data on it, and we're just kind of throwing a gamish of like sort of new agey stuff, right, around that for some people works. I think for others doesn't, right? And so for example, I went up to central Wisconsin where we've got a cabin, and I played the beginning of the playlist for one of the neighbors, and he goes, "What's this hippie shit? Like, I don't want that," And I think that's totally legitimate, right? That like we have this idea of what a psychedelic like space should be like, but I think that's a very narrow concept. Yeah. So there's good evidence to indicate that folks who are on SSRIs for chronically, so we're talking like 6-8 weeks, will have decreased subjective effects. There are active trials looking at whether tapering is essential. Basically, in all clinical trials, people are tapered off their SSRIs or TCAs or other antidepressants before entering the trial because the thought has been that those subjective effects are part of the therapeutic mechanism. Whether that's true, I guess, remains to be seen, but certainly there's a hugely diminished subjective effect of the psychedelics for folks who are on SSRIs. And so that's actually a really important sort of clinical question is how do we manage tapering people on or bringing people back onto their standard sort of maintenance antidepressants, given that it could be destabilizing, et cetera. Yeah.
You mentioned at the outset of your conversation, you appreciated that people coming out of a nice clean night to hear you up. We certainly appreciate you taking time out.
Thanks.
And it's really a good exemplification of those concepts. Wait, I haven't asked my question. I noticed among your collaborators that there was no one from the Department of Philosophy, and I wonder what all this work tells us about human reality. It seems as if the assumption here is that reality is a presentation of neural networks.
Mm.
And that perception is sort of a biochemical inner event that's crafted by our own experience. I know that there's work in transpersonal psychology that suggests there might be some kind of bedrock human event that isn't subject to the idiosyncrasies of our personal identities.
Yeah.
How
this dialogue a part of your work at all?
Yeah, so I would say, me personally, I mean, we have these conversations a lot. I would love that if we had more kind of philosophers engaged. It's certainly a part of my work in the context of the PPI program, because we are trying to be interdisciplinary. But I would say there's skepticism for me, and I think for others, that psychedelics are going to solve the so-called hard problem of consciousness, right? The other mind's problem. So how do I prove that you actually are a different conscious entity than me and aren't a projection of my own mind, and vice versa, right? You sort of can't know what it is to be something else. This is the hard problem of consciousness, right? So at the level of trying to understand consciousness as an entity, I don't think these are any better than other tools that we've got. They sort of don't have the epistemological weight that we would need. But for understanding sort of soft problems of consciousness, like how do we experience consciousness, what are other states, how do we integrate them, I think they're vastly interesting and important tools. I don't want to give you the impression that sort of the discourse around psychedelics is exclusively in this biomedical realm as it relates to what it means about our waking consciousness and the source of consciousness. But that's my lens, right? And if you talk to folks from indigenous traditions, for example, they'll tell you a very different story about what they're revealing about the nature of reality and our relationship to it. So. Yeah, I think that's one of our aims with this transdisciplinary center, is to incorporate, not just the biomedical, but a broader conversation around those kinds of things. You seem very excited to, okay. Okay, we'll go here. Nope. I have not. I need to make a trip abroad because I have a DEA Schedule I license, right? And so I can't risk losing that license. I think the work is really important, but given the opportunity to do it in a legal context, I think it would be an important source of information. Yes.
I think state of Oregon now has licenses.
Yeah. So there are places certainly to go. Yeah, I was going to go up here first.
Have you found use, I know you mentioned in the trials for Alzheimer's, have you found use or potential treatment in any type of neurological, that world, the dementia world?
Yeah, just really early days there. So similar to the question of, what else are people looking at this for? Because of that data, right, on sort of neuroplasticity, there is a lot of interest in neurological applications, so like post-stroke recovery, for example. And this is one of the areas where people are especially thinking about, can we have those neuroplastic effects without the overt psychological effects, without the altered perception, because that might actually introduce unnecessary risks. So can we differentiate these two things? To me, neurological applications are one of the areas where I think it makes the most sense to try and look for compounds that have kind of those neuroplastic rewiring pieces without the perceptual alterations. Now, whether that's possible sort of gets to the question of, is consciousness ultimately a phenomenon of what's happening at the neurobiological level? Yeah.
You said that in the long-term data that after a year it doesn't look as effective. Do you think this will actually turn into something that has to be repetitive and is a long-term therapy instead of a one-time?
So the data or I would say that the real world example that I can bring is ketamine clinics. So these are out there. People do ketamine infusions. There's also the intranasal one that I mentioned. Then there's also ketamine-assisted therapy clinics. And for ketamine infusions, people generally are coming back sort of once every 2 weeks. If it hasn't taken, this is sort of anecdotal from folks who are doing that work. They say if it hasn't taken, in 6 months, that you're not actually able to engage, with the therapy and use those tools to move on. They kind of stop, right, and say like this isn't it, because the risk is that you're just going there for this sort of like transient euphoria, right, and not actually working through the underlying pieces. So we'll see what the models look like. But at one point, the FDA was saying, maybe from a regulatory perspective, it's a one and done. You get like a one lifetime psilocybin pass, and you have to decide when to cash that in. I don't think that's how it's going to turn out, but yeah. I'll go to, sorry, you guys both already asked, yeah.
Well, I was going to ask about the racial aspect.
Yeah.
I know you said you felt like there was a lot more work that could be done in that area. Is one of the handicaps, perhaps, that, in your opinion, that a lot of the people doing the research are,
Absolutely, absolutely. I think that's one of our goals with the PPI program is to diversify the people who are actually doing this work, because overwhelmingly it's white male researchers. And I'm certain that has an effect on people's willingness to engage, especially given historical abuses in the medical community of marginalized groups. So yeah, I think we need to start from the ground up and develop researchers who look different than me in the field. Yeah.
You mentioned that whether their subjective trip was good or bad, they still saw positive results. Wouldn't that kind of lean then to what you're saying of like it really doesn't matter what they perceive, that the medicine does have subconscious effects?
Yeah, so I would say if you talk to Chris Nicholas or Chantel Thomas, who are sort of our study therapists, they would say it's grist for the mill, right? If it's a challenging experience or a negative one, what they'll talk about in those integration sessions is like, why did you find it challenging? Why do you think that was brought up? What does it reveal about what you need to change, right? So it's not that it's the subjective effect is irrelevant. It's that the perspective, right, that you gain can be turned into positive change for some people. Exactly. And again, that's not to say positive effect, negative effect doesn't matter, everybody gets better. That's not what I'm saying. I'm saying some people have a positive effect get better. Some people have a negative effect or a challenging effect get better. But I think that integration piece, right, and the opportunity to change is, my guess is that's what my colleagues would say, having heard them answer a similar question.
Thank you.
Yeah.
Does the psilocybin you use come from some natural source, or do you synthesize it?
Great question. Virtually the global source of psilocybin at the moment is Fitchburg, Wisconsin. So USONA has a decakilo processing plant that they just built that is synthetic. It's being made from indole building blocks. Putting the phosphate group on is the hardest part, which is annoying because it's basically a prodrug that falls off as soon as it goes in the body, but it does make it rock solid. Filament is a group in Canada that's starting to isolate. They're starting to extract psilocybin from mushrooms, but they're extracting the single ingredient. So my guess is you will start to see multiple sources. But there are groups in Oregon and Colorado, et cetera, who are using the whole mushroom, and there's all these debates about entourage effect or these other minor constituents actually doing something. But in the trials, synthetic psilocybin, either synthesized from building blocks or, in a few cases now, isolated from mushrooms as a single molecular entity. Yeah. Oh, sorry.
I'm very curious about your thoughts on big pharma.
Uh-huh. Yeah, so I think we talked about ethical dilemmas earlier. I think there's a massive ethical dilemma with big pharma and these compounds, given the source of the knowledge that's being used here. LSD is a semi-synthetic molecule. Mescaline is not. MDMA is a fully synthetic molecule. Psilocybin is not. I think treating them all in one bucket is probably not great. There are going to be people who innovate and create new versions, but for so-called legacy compounds or compounds that are natural products, personally, I am not comfortable with people patenting a product of nature and trying to make a buck off of it, especially on the backs of people who have held this knowledge as sort of sacred and intimate, and in some cases, not shared it with us freely, but it's been extracted like that. To me, that's very problematic. And the sort of thing we talk about a lot in the PPI program. But I do think there are models for innovation where pharma will not be unhelpful, where it's, can we shorten the duration? Can we cause there to be less of these psychedelic effects and still get neurologic effects, for example? So, yeah.
So in one of your photos up there, you had someone laying on a couch with headphones
Yeah.
and patches and stuff. So, I mean, and it was like, and you mentioned there was like, maybe a 6-hour session. So during these sessions, are people actually doing like therapy? And
So
are they talking about their, if it's PTSD, maybe it's abuse in the family at an early age, and they're revisiting that?
Yep.
Is that part of the?
So it depends on the compound. So for the MDMA, because that's an empathogen, right? That's a little different. The dosing session is an active therapy session. So they are doing this sort of interpersonal relationship and active therapy work. For psilocybin, the dosing session, it's basically there. The people are there to make sure nothing goes wrong, and all the therapy is happening outside of that session, basically. There might be a little bit of component of like, it's okay, you're all right, this is a safe place, but not really active therapy. For MDMA, it's different because they're just different psychological scenarios, yeah.
To piggyback on your question, my understanding is USUN is going through an open source model.
Yep.
That doesn't mean Big Pharma has to follow it.
Right.
But the broader question I have is 2 years, 5 years out. Are we going to see this evolve to like what's happened with marijuana, where it's Oregon and then it's California and then it's Colorado, and or is this something that the EU is likely to move on first? Because their regulatory process is substantially different than it is in the U.S. There's a substantial amount of this research that's being done worldwide, particularly at the University of London.
Yep. Yeah.
So I contend that if this data already was for a cancer breakthrough that was going to solve breast cancer, compassionate use authorizations would have already kicked in, and we wouldn't be having this discussion about what was going to happen down the road.
Yeah. So.
But compassionate use authorizations have been specifically blocked politically in Washington for the better part of the last 2 or 3 years, specifically regarding any of these uses.
Correct. Yes.
So I guess the broader question I have is that where do you see the politics of this going? Because
let me get out my crystal ball. No, I think the fault lines that you point out are very real. There are groups petitioning, going through the courts to try and say we have right to try legislation that's recently been put in place by a previous, Republican president and mixed Congress. This has been carved out as something that's not acceptable because of its DEA oversight, because it is Schedule I, it has no legitimate medical use. So it doesn't apply. People are fighting that out in the courts. They will continue to. From the sort of state-by-state level, I would say it's not going to happen in 2 or 5 years. It's going to happen in -2 years. I think there's parallel paths that are happening right now where there are folks pursuing clinical applications and FDA approval through the established pipeline. There are other folks making largely sort of libertarian-based arguments saying, this is not harming anyone else, it's my body, this is a product of nature, I should be able to use it, so we need to decriminalize or even recreationalize use, right? So those arguments are going to be more or less successful depending on the local political climate, but I think sometimes these two get conflated, right? That they are interdependent processes, when in reality, you could have A without B or B without A, or you could have A and B. And so I think that's where it's going to go is, Luke Rickard is our local historian. He gave a great talk called Psychedelic Wars. I think there's going to be a lot of internecine sort of conflict about what's the right way to use it, what's the right model. And that's actually not an easy problem to solve because people are coming at it from different sort of value propositions and value standpoints, right? Like what is important? Is it important that everyone has the right to access these as basically a benefit to humanity that nature has provided, or do safety concerns overrule that and we put them into the same sort of container that other cultures have deemed appropriate, that there's some restrictions around when and where it's appropriate. So to tell you how it's going to play out. I don't know. I will say, you said the EU, but Australia recently said that you can use access psilocybin if a provider basically requests it for you in a sort of compassionate use model. So I think other countries will move. Yeah.
Have you heard of any trials being done with psychedelics for severe ADHD? Would it work, something like that, theoretically work, treating that?
So whether it would work or not, I have to say I have no evidence or information to give you on that front because I don't believe there's been any published. I can't remember who is pursuing the trial. It might be Toronto, but don't quote me on that. If it is a US group, again, I would direct you to clinicaltrials.gov. If you type in, say, psilocybin, ADHD, it'll come up because you have to register your trial if it's in the US. I'm sorry I don't remember off the top of my head who's doing it, and doubly sorry I can't tell you whether I think it would work or not because I'm an evidence-based guy, right? And we don't have any evidence. Yeah.
I think on behalf of individuals suffering from mental illnesses, there's another element here, and that's an element of hope. Some of these individuals have struggled their entire life. They've recovered, gone into remission, only to fall back into states of deep depression and anxiety. And when this subject comes up, as is the case with other new developments, you see in their interest, their face, their responses, some sense of hope. There's a new frontier out there that's being explored. Maybe that will finally be the solution for me. And it's not just looking at that one element, a psychedelic drug. It's looking at their environment, their behavior, and other modalities. But I think what you're doing, the research you're doing, is important, and I think it is giving individuals with the need a sense of hope.
Thank you for that. I mean, it gives me a sense of hope. I mean, I couldn't continue. Being a scientist is not easy, like day to day, right? There's lots of things that go wrong and negative outcomes. And I mean, I couldn't continue to be one if I didn't think there was light at the end of the tunnel. Maybe not in my lab, maybe not in our exact studies, but as we build up the edifice of knowledge, I do deeply believe that the more we learn, the more tools we will have at our disposal. And I guess I'm naive enough to think that we will apply them to try and better the lot of humanity rather than worsen it. So whether this works out or not, I think hope is absolutely indispensable to the scientific enterprise and to the human condition. You mentioned the environment piece, and I just want to say one more thing on that too. I mentioned, psychedelic-assisted therapy, right, is one part of a bigger thing, but even that's part of a bigger piece. We've become a very individualistic and sort of fractured community, and we need that community. We need to be supporting one another, right? And so people in these trials often report a greater sense of connectedness to their loved ones, to nature, to humanity in general. And I think it's following up on that actually is some of the reason that those people who do have long-term outcomes without needing multiple dosing, that's some of the things that they report as to why it's so powerful in the long term, is that it changed how important they feel it is to connect and to be connected.
I think hope and connectedness is a great place to end. I want to thank our